Rhonda is a 55-year-old with a history of hypertension, diabetes, and coronary artery disease, who came to the emergency department with a 1-hour history of sudden chest pain that's described as, "Something's tearing inside my chest." She says this pain is different from the occasional chest pain she gets when she exercises. She was given nitroglycerin in the ER, but the pain did not improve. Her blood pressure is 175/95 in her right arm, but 130/80 in the left arm. An ECG shows left axis deviation, but no ST segment changes. Her troponin levels are normal. This is what her chest x-ray looked like. After seeing this x-ray, a CT of the chest was performed, and this is what that looked like. Okay, so the aorta is subject to a lot of stress, so a lot can go wrong. First, let's look at aortic aneurysms, which is an outpouching that occurs due to a weakening of the aortic wall. A true aneurysm involves all 3 vessel layers, the tunica intima, media, and adventitia. A dissection occurs when there is a tear in the tunica intima, allowing blood to literally dissect into the vessel wall. This may create the appearance of an aneurysm, but because it doesn't involve all 3 layers, it's a false or pseudoaneurysm. Now that we've got the basic terminology down, let's take a closer look at aortic aneurysms. These usually occur in the abdominal aorta, but can also occur in the thoracic aorta. The most high-yield and most important risk factor for abdominal aortic aneurysms is atherosclerosis. In atherosclerosis, chronic inflammation results in the release of enzymes called matrix metalloproteinases, or MMPs, which degrade the extracellular matrix in the tunica media, weakening the aortic wall. Abdominal aortic aneurysms, or AAAs, are most common below the origin of the renal arteries, which corresponds to the L2 vertebral level. This is because below this level, the abdominal aorta lacks vasa vasorum, which sounds like a graduation title, but are in fact small blood vessels in the adventitial layer that provide nutrients to the aorta itself. Therefore, the absence of vasa vasorum in this part of the aorta makes the tunica media particularly susceptible to ischemia. That's because in atherosclerosis, thickening of the intima makes it harder for oxygen to diffuse to the tunica media. Other important risk factors include age greater than 65, male sex, smoking, and a family history of abdominal aortic aneurysm. Now, abdominal aortic aneurysm is usually asymptomatic, but sometimes a pulsatile abdominal mass may be detected on physical exam. The most worrisome complication of AAA is rupture, which is more likely to occur when the aortic diameter exceeds 5 centimeters. It presents with a triad of sudden onset lower back or flank pain, hypotension from blood loss, and a pulsatile abdominal mass. Your exams will often not give you all 3, because in real life it's rare for the entire triad to appear. Other complications include formation of a thrombus, which could embolize to distal sites like the limbs or the renal arteries. Thoracic aortic aneurysms are less common, and they're not caused by atherosclerosis. Rather, they're associated with cystic medial degeneration. On microscopy, the tunica media appears fragmented, and small cleft-shaped spaces appear. Important risk factors you need to remember for your test include hypertension, bicuspid aortic valve, and connective tissue diseases like Marfan syndrome. Also, a high-yield fact is that tertiary syphilis can cause a small vessel vasculitis in the vasa vasorum of the thoracic aorta, also called obliterative endarteritis, which could lead to aneurysms. Now, a thoracic aortic aneurysm involving the ascending aorta can dilate the area where the aortic valve opening is, impairing the valve's ability to close during diastole. Therefore, you can sometimes hear an aortic regurgitation murmur. Okay, an aortic dissection is an intimal tear that allows blood to seep into and split the aortic wall, creating a second false lumen. Risk factors include hypertension, which is the most common cause, bicuspid aortic valve, connective tissue diseases like Marfan syndrome and Ehlers-Danlos syndrome, and the use of amphetamines or cocaine. An aortic dissection occurs due to the increased shearing forces against the intimal wall. Additionally, in hypertension, hyaline arteriosclerosis of the vasa vasorum weakens the aortic wall, making dissection more likely. Aortic dissection classically presents with sudden onset tearing chest pain that radiates to the upper back, between the scapula. On physical exam, the blood pressure in both arms may be unequal, and an aortic regurgitation murmur may be heard. A chest x-ray shows widening of the mediastinum, which is a helpful clue, but it's not a specific sign for aortic dissection. The diagnosis is usually confirmed with a CT scan, which shows a true and a false lumen. Aortic dissection is classified into Stanford Type A and Type B dissections. Type A dissections originate from the sinotubular junction, which is the initial portion of the ascending aorta. Type A dissections may extend to the aortic arch or the descending aorta. On the other hand, Type B dissections usually originate from the left subclavian artery and involve the aortic arch or descending aorta, but spare the ascending aorta. It's important to recognize the difference because the treatment differs. Type A dissections are treated surgically, while Type B dissections may be treated with beta blockers like esmolol. This is because in Type A dissections, rupture may cause blood to leak into the pericardial sac, resulting in a life-threatening cardiac tamponade, which is the most common cause of death. Kind of like a zipper, a dissection can extend into other arteries where the false lumen compresses the true lumen, obstructing blood flow and causing organ ischemia. A dissection can involve a range of arteries, including the carotids, resulting in stroke or syncope, the celiac trunk or mesenteric arteries, resulting in acute mesenteric ischemia, or the renal arteries, resulting in acute kidney injury, or the coronary arteries, resulting in a myocardial infarction. Finally, trauma can cause rupture of the aorta. This most often results from a deceleration injury, like in a motor vehicle crash. The most common site of rupture is at the aortic isthmus, which is just distal to the left subclavian artery branch. This is because at this site, the ligamentum arteriosum strongly tethers the aorta, so during a deceleration injury, this area is more prone to tearing compared to the relatively more mobile areas of the aorta. Alright, as a quick recap, aortic pathology includes aortic aneurysm and dissection. Risk factors for abdominal aortic aneurysm include atherosclerosis, age, tobacco smoking, and family history. This usually occurs below the renal arteries due to the lack of vasa vasorum. Abdominal aortic aneurysm is usually asymptomatic, but may present with a palpable pulsatile abdominal mass on examination. The most worrisome complication is rupture, which presents with back or flank pain, hypotension, and a pulsatile abdominal mass. Alright, back to Rhonda. Although she does have a history of coronary artery disease, which may present with chest pain, the tearing pain described by Rhonda was more characteristic of aortic dissection. Also, the ECG revealed no ST segment changes, and her troponin levels were normal, so a myocardial infarction is unlikely. The ECG did show left axis deviation, which is likely secondary to left ventricular hypertrophy, a complication of long-standing hypertension. Rhonda's chest x-ray showed a widened mediastinum, a common finding in aortic dissection. Fortunately, a CT was done, which caught a Stanford A dissection involving the ascending aorta. Rhonda is now recovering from her surgery and is now dissecting into a nice piece of chocolate cake.
Mikhail is a 60-year-old man with a history of hypertension, diabetes, and dyslipidemia who presents to your clinic complaining of sudden onset retrosternal chest pain associated with shortness of breath. He has a 35-pack a year smoking history, and he mentions that he also develops lower limb pain when walking for more than 15 minutes. His father underwent a below-the-knee amputation of his right lower extremity and died from a stroke. On physical examination, Mikhail's BMI is 32. On further workup, his ECG and high troponin levels suggest a myocardial infarction. Mikhail goes to the cath lab to undergo percutaneous coronary intervention, which showed a clot occluding the left anterior descending coronary artery. After the procedure, the chest pain resolved. However, he started developing a web-like skin rash. Mikhail suffers from arteriosclerosis, which is a hardening and thickening of the arterial wall, causing it to lose its elasticity. A specific type of arteriosclerosis is atherosclerosis, which is a chronic inflammatory disorder that affects the endothelium of medium and large arteries and is characterized by the buildup of cholesterol plaques within the arterial lumen. In a descending order, the most common arteries affected by atherosclerosis are the abdominal aorta, coronary artery, popliteal artery, and then the carotid artery. Risk factors for atherosclerosis can be divided into modifiable and non-modifiable risk factors. Modifiable risk factors include hypertension, diabetes mellitus, smoking, and dyslipidemia, particularly an increase in LDL levels or a decrease in HDL levels. Non-modifiable risk factors include age, family history, and being of African American descent. The pathogenesis of atherosclerosis is essentially an inflammatory response to endothelial cell injury. The endothelium is injured by stress against the arterial wall, like in hypertension. This is especially more prominent at arterial bifurcations, such as the carotid artery bifurcation. Other causes of endothelial injury include tobacco smoking and homocystinemia, which is elevated levels of the amino acid homocysteine. Regardless of the cause, when the endothelium is injured, LDL particles are allowed to leak into the intimal layer, where it gets oxidized. When LDL is oxidized, it becomes a pro-inflammatory antigen that induces an immune response in which inflammatory cells, like macrophages, come to fight this antigen. These macrophages will enter the arterial walls and eat up the oxidized LDL particles, creating what's known as foam cells. Accumulation of foam cells underneath the endothelium creates the first marker of atherosclerosis, a fatty streak. Fatty streaks might as well be called flatty streaks because they are not raised, meaning they don't obstruct the lumen, so they don't produce clinical symptoms like angina. Damage to the endothelium calls upon platelets to join the party. Platelet and endothelial cells release factors like platelet-derived growth factor, or PDGF, and fibroblast growth factor, or FGF, and transforming growth factor beta, or TGF-beta. These factors stimulate smooth muscle cell proliferation and migration from the tunica media to the tunica intima. Smooth muscle cells then proliferate and stimulate the production of extracellular matrix. This results in the formation of a fibrous cap overlying a lipid core in the center, and this structure is called a plaque. The lipid core is made of cholesterol crystals that under the microscope look like white slit-like spaces. The fibrous cap is what separates the lipid core from the blood vessel lumen. Unlike the fatty streak, an atherosclerotic plaque could obstruct the lumen and produce symptoms. Keep in mind that although fatty streaks can form as early as adolescence, they don't always develop into plaques. Now, over time, foam cells within the lipid core undergo necrosis and release matrix metalloproteinases, or MMPs. These enzymes begin chewing away at the fibrous cap, making it thinner and thinner until one day it ruptures. When this happens, the atheroma is now exposed to the blood vessel lumen. Platelets react as they should, by forming a fibrin clot at the site of rupture. Unfortunately, these clots can occlude the lumen of the artery even more, or they may detach and move to obstruct other blood vessels, like the arteries in the brain. Okay, complications of atherosclerosis include ischemia to the supplied organs. Typically, at least 70% of the lumen must be occluded prior to the onset of symptoms. Ischemia may manifest as angina if the coronary arteries are involved. claudication in peripheral vascular disease, or chronic mesenteric ischemia if the mesenteric arteries are involved. When the plaque ruptures, clot formation may potentially result in acute infarction of the supplied organ, such as myocardial infarction, ischemic stroke, acute limb ischemia, or acute mesenteric ischemia. Additionally, an atheroma may weaken the vessel wall, causing an aneurysm, especially at areas where the arterial wall is weaker. For example, these can occur in the abdominal aorta below the level of L2, since it lacks the vasovasorum, which are small blood vessels in the tunica adventitia, supplying the aortic wall. Without this vasovasorum, the tunica media doesn't get enough nutrients, causing it to weaken, which increases the risk of developing an abdominal aortic aneurysm that could rupture and cause hemorrhaging. An interesting complication of atherosclerosis are cholesterol emboli. This occurs when an atherosclerotic plaque itself is dislodged and travels in the circulation as a cholesterol embolus. A common exam question will have a person who underwent a cardiac procedure, such as a percutaneous coronary intervention, present with this complication right afterwards. This is caused by a plaque that was accidentally dislodged during the procedure. Symptoms depend on where the embolus ends up and include a web-like purplish rash called livedo reticularis, acute kidney injury, or even gangrene formation at the extremities. Retinal emboli can be visualized on fundoscopy and are called Hollenhorst plaques. A good clue is that laboratory investigations, interestingly, show eosinophilia, and urinalysis shows eosinophiluria. Microscopically, cholesterol emboli are characterized by white needle-shaped cholesterol clefts within the occluded vessel lumen. Okay, another subtype of arteriosclerosis is arteriolosclerosis. A bit of a tongue twister. From the name, this affects smaller arterioles, and there are two types: hyaline and hyperplastic arteriolosclerosis. Hyaline arteriolosclerosis results from deposition of protein within the vessel wall, which on microscopy gives off a glassy, eosinophilic pink appearance, hence the term hyaline. Accumulation of protein thickens the blood vessel wall and makes it rigid, occluding the arteriolar lumen. Risk factors include chronic hypertension or diabetes. In hypertension, the increased arterial wall stress literally pushes plasma proteins into the blood vessel wall. In diabetes, excess glucose combines with the proteins of the arteriolar basement membrane, a process called non-enzymatic glycation. Having too much sugar in the basement membrane is not a good idea, because it can disrupt the structure and allow plasma proteins to leak in. Clinical manifestations of hyaline arteriolosclerosis include hypertension and diabetic nephropathy, as well as small lacunar infarcts in the brain. Hyperplastic arteriolosclerosis, on the other hand, typically happens as a reaction to severe acute elevations in blood pressure. This results in excessive growth of the basement membrane and proliferation of the arteriolar smooth muscle, which occludes the lumen and gives the blood vessel the appearance of onion skin on microscopy. Hyperplastic arteriolosclerosis most commonly affects the renal, retinal, and intestinal arterioles. The final form of arteriosclerosis is an uncommon and benign form called medial calcific sclerosis, or Monckeberg sclerosis. This form is characterized by calcification of the internal elastic lamina and tunica media, causing the vessel wall to become rigid. But the thing is, although the blood vessel is rigid, the lumen is not occluded, so it's not clinically significant and should be ruled out as an answer choice if the person suffers from symptoms of ischemia. These calcifications may appear on X-ray, giving the blood vessel a pipe stem appearance. Okay, to review, arteriosclerosis is hardening of the arteries and has different subtypes, including atherosclerosis, hyaline, and hyperplastic arteriolosclerosis, and medial calcific sclerosis. Atherosclerosis results from endothelial injury secondary to risk factors like age, hypertension, diabetes, and tobacco smoking. When the endothelium is injured, LDL particles enter and are oxidized. Macrophages phagocytose LDL particles, forming foam cells, which forms the fatty streaks. Smooth muscle cells proliferate and migrate to the intimal layer, where they lay down extracellular matrix. Over time, an atherosclerotic plaque made of a fibrous cap and a lipid core is formed. This plaque may occlude the lumen, causing ischemia to distal organs, which manifests as angina or claudication. When the plaque is disrupted, a thrombus is formed, which may produce acute infarction, such as myocardial infarction or stroke. Atheromas can also weaken the vessel wall, resulting in the formation of aneurysms, like abdominal aortic aneurysm. Also, during cardiac procedures, atherosclerotic plaques can be dislodged, producing cholesterol emboli. Hyaline arteriolosclerosis is associated with chronic hypertension and diabetes, and is characterized by protein deposition in the vessel wall. Hyperplastic arteriolosclerosis is associated with severe acute hypertension and is characterized by expansion of the basement membrane. Finally, medial calcific sclerosis is a benign condition characterized by calcification of the tunica media, which can be visualized on X-rays. Back to our case. Mikhail had multiple risk factors for atherosclerosis, including old age, hypertension, diabetes, obesity, tobacco smoking, and dyslipidemia. He also had a family history of atherosclerosis, as his father likely had a peripheral vascular disease and died from a stroke. Mikhail presents with chest pain characteristic of myocardial ischemia, which was confirmed by his ECG and troponin levels. His lower limb pain on exertion is characteristic of claudication, which is most likely caused by peripheral vascular disease. After his cardiac procedure, he developed a web-like rash that is likely levodoreticularis, indicating that this procedure was complicated by a cholesterol embolus.
Two people came to the clinic one day. Kara is a 66-year-old woman who came to the clinic after noticing gradually developing left arm swelling and redness over the past 3 months. Physical examination reveals a tender, purplish lesion along the left armpit. She has a history of hypertension, diabetes, and breast cancer that was treated 10 years ago with a modified radical mastectomy and radiation therapy. Clay is a healthy 1-year-old infant brought by his parents due to a rapidly growing red bump on his face. He has no history of trauma, and the lesion didn't appear anywhere else. Physical examination reveals a raised, bright red nodule on the left side of his face and no other abnormal findings. Now, both Kara and Clay have vascular tumors. There are many types, so it's best to classify them into benign and malignant tumors. Let's start with the most common benign vascular tumor in children, the strawberry hemangioma, where hemangioma means a benign tumor of the blood vessels. A strawberry hemangioma appears as a superficial, bright red skin lesion that looks kind of like a strawberry, and they commonly affect the face. Histologically, these lesions are confined to the epidermis. Now, a typical strawberry hemangioma develops in infancy and grows pretty fast, but fortunately, it goes away on its own by 5 to 10 years of age. So in terms of management, exams like to bring up a very concerned parent, but the correct answer will almost always be to reassure the parent that the lesion will regress without treatment. Now, a related disorder is cherry hemangioma, which is the most common benign vascular tumor in adults. This tumor appears dark red like a cherry. Histologically, this lesion extends to the superficial papillary dermis, so they reach much deeper than strawberry hemangiomas. These tumors increase in frequency with age, and unlike strawberry hemangiomas, they do not regress spontaneously. Cavernous hemangiomas are soft, bluish lesions, and unlike strawberry and cherry hemangiomas, they're usually seated in the deep dermis. The word cavernous means cavern-like, so it's not surprising that histologically these appear as large, endothelium-lined spaces filled with red blood cells. Cavernous hemangiomas can also be located in organs like the liver, spleen, and even the brain. Also, von Hippel-Lindau syndrome is an autosomal dominant condition that causes numerous tumors and cysts throughout the body, one of these being cavernous hemangiomas of the cerebellum and the retina. Look for a history of bilateral pheochromocytoma or renal cell carcinoma. The next tumor is cystic hygroma, or a cavernous lymphangioma. It's a benign tumor of the lymphatic vessels that typically arises in the neck, and it's associated with both Down and Turner syndrome. Histologically, this tumor is made up of endothelial lining, but the difference between it and hemangiomas is the absence of red blood cells, because lymphatic vessels have lymphatic fluid in them, not blood. Next up, we have pyogenic granuloma, which is the biggest misnomer in medicine. First, it doesn't produce pus, and histologically, it's not a granuloma. Instead, this is a benign, polyploid, or dome-shaped hemangioma that can ulcerate and bleed. Histologically, the tumor shows lobules made of proliferating capillary and edema, which makes it look like granulation tissue. Board exams will often give you risk factors, such as history of trauma to the area or pregnancy, especially in the first trimester. Next are glomus tumors. These arise in the glomus bodies, which are small arteriovenous shunts located in the dermis. They help regulate body temperature by shunting blood away from the skin in cold temperatures, and to the skin when it's hot. A glomus tumor usually arises from the smooth muscle cells in the glomus bodies, and they're painful, bluish-reddish tumors most commonly found under the fingernails. An important differential diagnosis is subungual melanoma, which appears similarly, but the difference is the presence of melanin-pigmented cells on histology, so it's important to get a biopsy. The next two tumors are associated with HIV. There's bacillary angiomatosis, which is benign, and Kaposi sarcoma, which is malignant. Bacillary angiomatosis is not technically a tumor. It's an infection caused by the gram-negative bacillus Bartonella henselae. It's thought that the bacteria enters the intravascular compartment and releases angiogenic factors that stimulate benign endothelial cell proliferation. Kaposi sarcoma, on the other hand, is a malignancy of the endothelial and smooth muscle cells caused by human herpes virus 8, or HHV8, or by HIV. It's still unknown exactly how these viruses cause malignancy. Now, both conditions appear as red-violet papules on the skin. Kaposi sarcoma also tend to affect the buccal mucosa as well as the gastrointestinal and respiratory tracts. So, beware for questions that pose Kaposi sarcoma as a case of GI bleeding or hemoptysis. The best way to differentiate the two is microscopically. Bacillary angiomatosis shows gram-negative bacilli using Wharton's starry stain, as well as neutrophilic infiltrate. On the other hand, Kaposi sarcoma shows spindle-shaped tumor cells along with a lymphocytic infiltrate. Okay, another malignant tumor of the blood vessels is angiosarcoma, which is a cancer of the endothelial lining of the blood vessels. These are more common in older people and affect sun-exposed areas like the head and neck. If the person has a history of radiation therapy, like for breast cancer, they can also develop. A specific type is hepatic angiosarcoma, which is linked to chronic exposure to arsenic and pesticides, polyvinyl chloride, or PVC, which is a plastic commonly used in industry, and thorotrast, an old contrast medium. A helpful clue is that hepatic angiosarcoma cells express CD31, also called PCAM1, which is normally expressed on the surface of endothelial cells and acts as a binding point for leukocytes. However, in angiosarcoma, CD31 promotes angiogenesis, which is how these tumors develop. This is a way your exams can connect this pathology with normal physiology. Lymphangiosarcoma is similar to angiosarcoma, except it involves the lymphatic vessels. The main risk factor is chronic lymphedema, which can arise after a mastectomy or lymph node dissection for breast cancer. Alright, now that we've looked at the vascular tumors, let's shift gears and go over the cardiac tumors. The most common primary cardiac tumors in adults are myxomas. Myxoma is derived from myxoid, which means connective tissue. So, myxomas are benign tumors derived from undifferentiated connective tissue cells in the heart. A high-yield fact is that most of them occur in the atria, especially in the left atrium. The tumor obstructs blood flow through the mitral valve, causing a decrease in the left ventricular stroke volume. Remember for your tests that a common presentation is multiple episodes of syncope. Other symptoms include shortness of breath on exertion and palpitations. Atrial myxomas produce vascular endothelial growth factor, or VEGF, which promotes angiogenesis, making the tumor friable and more likely to bleed. Myxomas also make interleukin-6, a cytokine that leads to systemic symptoms like fever and weight loss. Exams can use this information to tie in concepts relating to immunology, like the fact that interleukin-6 is also responsible for the production of acute phase reactants, like CRP and fibrinogen. So, they could use a scenario of an atrial myxoma and ask, the cytokine produced by the pathology this individual has is also responsible for auscultation of the heart apex shows the classic tumor plop sound during diastole. Transesophageal echocardiography, or TEE, confirms the diagnosis, revealing a pedunculated mobile mass in the atrium. The reason we go through the esophagus is because it's directly posterior to the left atrium, providing us with a good view of the left atrial chamber. Microscopically, scattered connective tissue cells are seen mixed with a gelatinous mucopolysaccharide stroma. Okay, now the most common primary cardiac tumor in children is cardiac rhabdomyoma. Rhabdomyomas are hamartomatous growths of the cardiac muscle. Hamartomatous means benign hyperplastic growth, meaning there's no neoplasia. The vast majority of cardiac rhabdomyomas are associated with tuberous sclerosis, a genetic disorder that causes tumor formation in various other organs like the brain, eyes, lungs, liver, and kidneys. A big clue is adenoma sebaceous, which are flat, reddish lesions on the skin that resemble freckles. Alright, as a quick recap, vascular tumors are benign or malignant. Benign tumors include strawberry hemangiomas, which appear in infants and go away spontaneously, and cherry angiomas, which appear in older people and do not regress spontaneously. Cavernous hemangiomas are more deep-seated in the dermis and can also involve internal organs like the brain. Cystic hygromas are lymphangiomas located in the neck and are classically associated with Down and Turner syndrome. Pyogenic granulomas are pedunculated and are associated with trauma and pregnancy. Glomus tumors are benign tumors of the thermoregulatory glomus bodies and are located underneath the fingernails. Bacillary angiomatosis is caused by Bartonella henselae, while Kaposi sarcoma is caused by HHV8, and both are associated with HIV. Hepatic angiosarcoma is associated with exposure to arsenic, PVC, or thorotrast. Lymphangiosarcoma is associated with chronic lymphedema, such as after a radical mastectomy. Cardiac tumors include atrial myxoma, which is the most common in adults, and rhabdomyoma, which is the most common in children. Alright, back to our cases. Considering the appearance and location of Kara's lesions, it's likely that she has lymphangiosarcoma, which is caused by her previous modified radical mastectomy. Next, because of his young age and the appearance of the tumor, Clay likely has a strawberry hemangioma, and his parents were reassured that the lesion usually goes away on its own.
Mikey is a 22-year-old male college student from Vermont who was sent to the emergency department after passing out. His vital signs show a heart rate of 40 beats per minute and a blood pressure of 90/50. On examination, there is an erythematous circular rash with central clearing. His friends mention that they recently went on a hiking trip. His ECG is as follows. Natasha is a 60-year-old female with chronic hypertension, diabetes, and peripheral vascular disease who comes to the emergency room complaining of sudden onset, squeezing retrosternal chest pain accompanied by shortness of breath and sweating. Her ECG is as follows. On laboratory evaluation, her troponin levels are significantly elevated. Alright, so the normal electrical activity of the heart starts in the sinoatrial, or SA, node, located near the opening of the superior vena cava into the right atrium. Electrical activity is then conducted through the atrium to the atrioventricular, or AV node, after which it goes through the bundle of His, then the right and left branches of the bundle, and finally through the Purkinje fibers, which deliver the current to the right and left ventricles. Now, normally there's a delay in conduction at the AV node and the bundle of His, which gives some time for ventricular filling before the ventricle contracts. A heart block, or AV block, occurs when conduction is delayed for too long at the AV node or the bundle of His. Also, electrical activity may be blocked at the level of the bundle branches, which are called bundle branch blocks. Okay, on the ECG, the normal delay in the AV node is represented by the PR interval, which is normally less than 5 small boxes, or 200 milliseconds. There are 3 main types of AV block. First-degree AV block is technically not really a block, it's more of a delay. Every single atrial impulse eventually makes it to the ventricles. The high-yield concept here is that the only abnormality is a prolonged PR interval, and it's usually asymptomatic, so it doesn't require treatment. Second-degree AV block has 2 subtypes, Mobitz 1 and Mobitz 2. In Mobitz 1, each atrial impulse encounters a longer and longer delay until one of them doesn't make it through to the ventricles. The high-yield concept here is that on the ECG, this is reflected as the PR interval getting progressively longer and longer until all of a sudden the heart drops a beat. Like in Mobitz 1, the heart also drops a beat in Mobitz 2, except this time conduction through the AV node is all or nothing. Either the atrial impulse goes through with no delay, or it doesn't go through at all. Basically, there's no progressive prolongation of the PR interval in Mobitz 2. On the ECG, Mobitz 2 shows a couple of normal PR intervals followed by a dropped beat. Also, like first-degree AV block, Mobitz 1 is usually benign and doesn't require treatment unless it's causing symptoms. On the other hand, Mobitz 2 can be dangerous and may result in severe bradycardia and decreased cardiac output. Therefore, it requires treatment with a pacemaker. Now, Mobitz 2 blocks can sometimes progress to our next type, the dangerous third-degree AV block. In this type, none of the electrical impulses are conducted through the AV node, and that's why it's also called complete heart block. Now, remember that all cardiomyocytes are capable of starting their own electrical activity, a property called automaticity. So, in third-degree AV block, the ventricles recognize that they're not getting any impulses, and respond by generating their own electrical rhythm called a ventricular escape rhythm, just to hang on to dear life. Because the atria and the ventricles each have their own pacemakers, they now contract independent of one another, which is called AV dissociation. This desynchronization of the heart chambers can reduce cardiac output dramatically, leading to syncope or even sudden cardiac death. On the ECG, the P waves and QRS complexes have nothing to do with each other, each appearing at their own rates. The atrial rate is 60 to 100 beats per minute, whereas the ventricular rate usually ranges between 30 and 45 beats per minute. Because of how dangerous third-degree blocks are, anyone diagnosed with it needs a pacemaker. Alright, so a lot of things can cause the three types of AV block. A myocardial infarction may involve the conduction pathway, causing a delay in electrical conduction. This is especially common in right coronary artery occlusion because it gives off a small branch that supplies the AV node. On the exam, a clue towards right coronary artery occlusion would be a case of inferior wall myocardial infarction, indicated by elevation of the ST segments in leads 2, 3, and AVF. Also, electrolyte disturbances like hyperkalemia can alter the membrane potential. Then there are external causes like Lyme disease, medications such as beta blockers, calcium channel blockers, adenosine, amiodarone, and digoxin. For your exams, remember that Lyme disease is typically associated with third-degree AV block. Interestingly, congenital heart block is a complication of neonatal lupus, which could also show up on your exam. Here, the maternal autoantibodies, called anti-Rho and anti-La antibodies, cross the placenta and attack the conduction system. AV block may also be a normal variant in some circumstances, like in athletes. The next type of conduction block occurs in either the left or right branches of the bundle of His, and are called bundle branch blocks. In normal ventricular depolarization, the QRS complexes are narrow, that is, less than 3 small boxes or 120 milliseconds. As a general rule of thumb, all bundle branch blocks cause the QRS complexes to appear wide. This is because we're delaying the time for complete depolarization of both ventricles. In right bundle branch block, or RBBB, the high yield fact to remember is that the QRS complexes in the right-sided chest leads V1, V2, and V3 show an RSR configuration. This means a pronounced R wave, followed by a deep S wave, and then another R wave. This gives the QRS complex the appearance of rabbit ears, or the capital letter M. To remember this, think RBBB equals rabbit ears in the right-sided chest leads. Causes of RBBB include right ventricular hypertrophy, right heart failure, and pulmonary embolism. These causes are due to the right heart not functioning normally, so there is delayed conduction through the heart tissue. Also, for unknown reasons, RBBB can be present in normal hearts, possibly due to deposition of fibrous tissue that interrupts the conduction pathway. Now let's look at left bundle branch block, or LBBB. Similar to RBBB, the QRS complexes will be wide because of the delay in ventricular depolarization. In leads 1, AVL, V5, and V6, tall R waves are present, and in lead V1, broad deep S waves are characteristic. Additionally, there may be ST segment depression and T wave inversion. Now, unlike RBBB, LBBB never occurs in normal hearts, so there's always something wrong. Examples include hypertension, ischemia, dilated cardiomyopathy, and aortic stenosis. Similar to the causes of RBBB, these disorders affect the left ventricle, causing a delay in conduction through the cardiac tissue. Importantly, a new LBBB in an individual presenting with chest pain may be a sign of myocardial infarction. Alright, as a quick recap. AV node block is divided into 3 major subtypes. First-degree AV block is simply a prolonged PR interval. Second-degree AV block has 2 subtypes, Mobitz 1 and Mobitz 2. Mobitz 1 is characterized by a progressively prolonged PR interval followed by a dropped beat. Mobitz 2 has a normal PR interval followed by a sudden dropped beat. In third-degree AV block, there is no relationship between the P waves and QRS complexes, a phenomenon known as AV dissociation. Bundle branch blocks also have a wide QRS complex. In RBBB, an RSR complex, or rabbit ears, appears in the right-sided precordial leads. In LBBB, there are tall R waves in leads 1, AVL, V5, and V6, as well as deep S waves in lead V1. Alright, back to our cases. Mikey is presenting with syncope, so let's take a look at his ECG. We see that there is no relationship between the P waves and the QRS complexes. Each one is appearing at their own rate. This indicates a third-degree AV block. Considering he recently went on a hiking trip in Vermont and he's got a bullseye rash, it's likely that the cause of his AV block is Lyme disease. Mikey was treated with intravenous antibiotics and is now off planning his next hike. Okay, on to Natasha's ECG. First, we see that the QRS complexes are wide in all the leads, but that's not really specific for anything. Looking closer at leads 1, AVL, and V6, we see those characteristic tall R waves. Also, lead V1 shows a broad S wave. These characteristics are indicative of left bundle branch block. Considering Natasha is presenting with chest pain and her troponin levels are elevated, this new LBB may be indicative of an acute myocardial infarction.
The pericardium is a sac that covers the heart and the roots of the great vessels. The pericardium has two layers, an inner serous layer and an outer fibrous layer, and the space between the two layers is the pericardial cavity. The pericardial cavity is normally filled with about 50 milliliters of serous fluid that cushions the heart from any kind of external jerk or shock, like a shock absorber. The pericardium also fixes the heart to the mediastinum to prevent it from twisting, so that the big vessels don't get pinched shut. Pericardial disease is inflammation of the pericardium due to a variety of causes, from infections to autoimmune disorders, cancer, and trauma. In pericarditis, the pericardium is inflamed and irritated. If the inflammation leads to the accumulation of excess fluid in the pericardial sac, then it's called a pericardial effusion, and in its worst form, that extra fluid can cause tamponade physiology. Finally, there's constrictive pericarditis, which is where the inflammation is chronic and leads to fibrosis. In pericarditis, the two inflamed layers of the pericardium rub against one another every time the heart beats. This causes severe, sharp retrosternal chest pain that radiates to the neck, shoulders, and back, and it typically happens with each breath during inspiration. That's because in inspiration the lungs expand, filling the thoracic cavity and compressing the pericardium. The pain typically worsens when a person is supine and improves when a person is sitting upright and leaning forward. Upon auscultation, there's a pericardial friction rub, which is a scratchy, grating, high-pitched rub resembling the sound of leather on leather rubbing against each other. On ECG, there's widespread ST segment elevations in several leads, which distinguishes it from the ST elevation in myocardial infarction, which is only present in the leads that correspond to the infarcted tissue. Also, a very specific ECG finding in pericarditis is PR segment depression. Pericarditis also causes generalized inflammation, so there's often an elevated white blood cell count, ESR, and CRP. In addition, it's important to obtain troponins to rule out conditions like a myocardial infarction. Since pericarditis can lead to pericardial effusion, a transthoracic echocardiography is used to look for a pericardial effusion. In addition, it can be used to look for wall motion abnormalities, which are widespread in acute pericarditis, but limited to the area of infarct in a myocardial infarction. Diagnosis of acute pericarditis is based on having the typical chest pain, a friction rub on auscultation, suggestive ECG findings, and evidence of a pericardial effusion. Most cases of acute pericarditis are uncomplicated and self-limited, and most of the time there's no clear cause identified, or it's thought to be viral pericarditis, like from Coxsackie virus. and supportive treatment is given to ease the pain and inflammation. Non-steroidal anti-inflammatory drugs, or NSAIDs, like ibuprofen or aspirin, usually work for pain relief. If NSAIDs aren't enough, they can be combined with colchicine, which inhibits neutrophil motility and has an anti-inflammatory effect. In some cases of acute pericarditis, corticosteroids may be used to calm the inflammation, but the use of corticosteroids is a risk factor for recurrence, so they should only be used if NSAIDs and colchicine aren't sufficient. Finally, if there's an underlying cause for the pericarditis, then it should be treated. For example, if there's a cancer of a surrounding tissue or organ, like a lymphoma, lung, breast, or esophageal tumor, then in some cases, chemotherapy can be injected directly into the pericardial sac. Similarly, if the underlying cause is a bacterial or tuberculosis infection, then antibiotics can help treat the pericarditis. In a pericardial effusion, the pericardial sac can fill up with up to 200 milliliters of fluid acutely, and over a liter of fluid if it accumulates slowly. Small effusions can be asymptomatic unless they're associated with pericarditis, whereas a large effusion can cause symptoms of cardiac tamponade. That's where the fluid around the heart prevents the ventricle from relaxing enough to accept blood, which lowers cardiac output and causes hemodynamic compromise, which can ultimately lead to shock. But timing matters, and if the effusion occurs rapidly enough, then even 100 milliliters can cause cardiac tamponade. Cardiac tamponade is life-threatening and causes Beck's triad, which is hypotension due to the impaired cardiac output, jugular venous distension due to blood backing up, and muffled heart sounds on auscultation because of the extra fluid between the heart and the stethoscope. In fact, larger effusions can cause Ewart's sign, which is dullness to percussion over the last subscapular area due to compression of the left lung base. On ECG, a large effusion can cause low voltages across many of the leads due to the increased distance from the chest leads. It can also cause electrical alternans, which is where the readings shift from heartbeat to heartbeat due to the heart jiggling around a bit with the effusion. And in cardiac tamponade, classic ECG findings include sinus tachycardia and a low QRS complex voltage. On an X-ray of a heart with a large pericardial effusion, you can see a silhouette that pools to the bottom of the heart and gives a classic water bottle sign. And a large pericardial effusion of at least 200 milliliters causes cardiomegaly. That's a large cardiac shadow that blurs out the distinction between the arch of the aorta and the left ventricle. Echocardiography is the main diagnostic tool used in the evaluation of pericardial effusion, showing the excess fluid creating an echo-free space between the two pericardial layers. Echocardiography gives a very clear picture also on the extent of the effusion, which is directly proportional to the separation between the layers. The effusion can be small, moderate, or large. For circumferential pericardial effusions, a pericardial effusion that has less than 10 millimeters of pericardial separation in diastole is small and corresponds to a fluid volume of 50 to 100 milliliters. 10 to 20 millimeters of separation is moderate and corresponds to a fluid volume of 100 to 500 milliliters. And greater than 20 millimeters separation is large and corresponds to a fluid volume greater than 500 milliliters. Additionally, on an echocardiogram, a pericardial effusion makes the heart look like it's dancing within the pericardium. In case of cardiac tamponade, echocardiography often shows collapsed ventricles. During inspiration, the negative pressure in the thoracic cavity leads to increased pressure into the right ventricle, which causes the interventricular septum to bulge toward the left ventricle, leading to decreased filling of the left ventricle. At the same time, the right ventricle volume is markedly diminished and sometimes its free wall can collapse. Finally, cardiac catheterization measures the pressure inside the cardiac chambers, and in the case of tamponade, the pressure in all four chambers is equal. If the cause of the pericardial effusion is unclear, pericardiocentesis can be done to obtain and analyze the pericardial fluid. If the fluid looks bloody or hemorrhagic, with a red blood cell count above 100,000 millimeters cubed, it's suggestive of trauma, malignancy, or pulmonary embolism. If the fluid is chylous, then it suggests there's been an injury to the thoracic duct, often accidental trauma during surgery, or due to leukemic infiltration, where leukemic cells fill up the pericardial sac. Finally, if the fluid is purulent, then it should be sent for a white blood cell count, gram stain, culture, cytology, and a determination of glucose, protein, and LDH levels. An elevated white blood cell count may be present with both inflammatory and infectious causes. An elevated protein level higher than 6 grams per deciliter and a glucose level below 60 milligrams per deciliter suggest an infectious cause like a bacterial or tuberculosis infection, or an inflammatory cause like an autoimmune process or malignancy. An isolated increased fluid LDH level above 300 units per deciliter with a normal serum LDH level suggests a malignancy. In terms of treatment, some pericardial effusions are small and naturally get resorbed by themselves over time. Pericardial effusions that are larger than 20 millimeters and persist for more than a month may be drained. In individuals with recurrent small pericardial effusions who don't have symptoms and don't have evidence for hemodynamic compromise, regular follow-up with echocardiography is recommended. Any individuals that develop cardiac tamponade require emergency pericardial drainage by pericardiocentesis. That's where a needle is inserted laterally through the fifth intercostal space, into the pericardial space, and fluid is aspirated with ultrasound guidance. A drainage tube is often left in place if reaccumulation of fluid is likely. In some cases, drainage might require surgically cutting through the pericardium to create a pericardial window, so the fluid can leak out. In hypotensive patients, volume expansion with intravenous fluids and blood products may also be needed. Finally, there's constrictive pericarditis, which is a chronic process that results in fibrinous scarring and calcification of the pericardium. The pericardium becomes a rigid box that forms a non-compliant shell around the heart, limiting the heart's ability to expand and function normally. So when blood enters the heart, the walls of the heart relax back into this rigid box, creating the so-called pericardial knock during diastole on auscultation, which is due to the sudden termination of ventricular inflow by the encasing pericardium. There are no specific electrocardiographic findings in constrictive pericarditis. Nonspecific ST and T wave changes and tachycardia are common, and low voltage may also sometimes be present. Advanced cases may also develop atrial fibrillation due to stretching of the atrial walls due to increased atrial pressures. Two-dimensional echocardiography may also show a thickened pericardium, abrupt cessation of left ventricular and right ventricular diastolic filling, biatrial enlargement, and an interventricular septal shift with flattening and left-sided deviation of the interventricular septum. That, in turn, causes a decreased volume in the left ventricle. Also, there's excessive variations in transmitral, transtricuspid, pulmonary venous, and hepatic venous blood flow due to respirations. Doppler echocardiography shows an abnormally rapid early diastolic filling associated with a small ventricular volume. Cardiac magnetic resonance is sometimes done to help differentiate a small pericardial effusion from pericardial thickening. In the majority of cases, constrictive pericarditis is permanent and often progressive. The only definitive treatment option is pericardiectomy or pericardial stripping, which is a surgical procedure where the entire pericardium is peeled away from the heart and removed. Alright, as a quick recap. In acute pericarditis, there's widespread inflammation of the pericardium, which causes an elevated white blood cell count, ESR, and CRP. On ECG, there's widespread ST segment elevation in several leads, as well as PR segment depression. The treatment is usually anti-inflammatory medications like NSAIDs, and it can be combined with colchicine. If there's fluid accumulation in the pericardial sac, you get a pericardial effusion, filling with up to 200 milliliters of fluid acutely, and over a liter of fluid if it accumulates slowly. Small effusions can be asymptomatic unless they're associated with pericarditis, whereas a large effusion may cause symptoms of cardiac tamponade. Some pericardial effusions remain small and never need treatment. Individuals that develop cardiac tamponade require immediate hospital admission and prompt pericardial drainage by pericardiocentesis and potentially volume expansion. And finally, there's constrictive pericarditis, which results in fibrinous scarring and calcification of the pericardium, limiting the heart's ability to expand and function normally. The definitive treatment is pericardiectomy or pericardial stripping.
Two people came into the emergency department. One of them is 55-year-old Pamela, who has sharp retrosternal chest pain that gets worse when she breathes in. On chest auscultation, a friction rub can be heard. The other person is 43-year-old Thomas, who had been in a car accident and now presents severe hypotension, and on physical examination, his neck veins are distended and his heart rate is really high. On chest auscultation, there's barely audible heart sounds. An ECG was ordered for both individuals. Pamela had ST segment elevation in several leads and also PR depression, while Thomas has low voltage QRS complexes. Okay, based on what we know about the individuals, we can assume that both suffer from pericardial disease. But first, a bit of physiology. The pericardium is a sac that covers the heart and the roots of the great vessels. The pericardium has two layers, an inner serous layer and an outer fibrous layer. The space between the two layers is the pericardial cavity that cushions the heart from any kind of external jerk or shock, kind of like a shock absorber. The pericardium also fixes the heart to the mediastinum to prevent it from twisting so that the large vessels don't get pinched shut. Now, for pericardial disease, we should start by talking about inflammation in the pericardium, which is called pericarditis. People who develop pericarditis are also at risk of developing a pericardial effusion where the inflammation causes fluid to accumulate around the heart. Pericarditis is in most cases idiopathic. It can also be due to a viral infection, like Coxsackie-B virus. Pericarditis can also be seen in autoimmune diseases, like rheumatoid arthritis or systemic lupus erythematosus, because the immune system attacks our own tissues, including the pericardium. For your exams, other high-yield causes include myocardial infarction and Dressler syndrome, which occurs several weeks after a myocardial infarction. Basically, when heart cells die in a myocardial infarction, it attracts white blood cells to the area, leading to massive inflammation that also involves the serous pericardium. Another cause is uremia, which is when the blood levels of urea get really high, and this usually happens due to kidney failure. The high levels of urea irritate the serous pericardium, making it secrete a thick pericardial fluid that's full of fibrin strands and white blood cells. Cancers like lung and lymphoma can also lead to pericarditis, due to metastasis that reach the pericardium, irritating it. Finally, there's radiation therapy that can also lead to pericarditis. Now, inflammation of the pericardium causes the fluid and immune cells in tiny blood vessels in the fibrous and serous pericardium to leak into the interstitium of those layers, making the layer itself a bit thicker and more boggy. Think of how a piece of dry sponge thickens as it soaks up fluid. Now, sometimes, when the inflammation persists, immune cells can initiate fibrosis of the serous pericardium, which can produce an inelastic shell around the heart, making it hard for the chambers to expand, and this is called constrictive pericarditis. For your tests, remember that the most common cause of constrictive pericarditis in high and middle income countries is idiopathic or viral infection, while in lower income countries, it's tuberculosis. In a test question, it might often appear as a consequence of chest radiotherapy. Now, both ventricles can't fully expand and fill with blood. So from the left ventricle, all that blood backs up into the lungs, specifically in the pulmonary veins and capillary beds, which can increase the pressure in these vessels. This leads to fluid moving from the blood vessels to the interstitial space, causing pulmonary edema, or congestion. In the alveoli of the lungs, all the extra fluid makes oxygen and carbon dioxide exchange a lot harder, and therefore, patients have dyspnea or trouble breathing. And from the right ventricle, blood accumulates in the veins of the systemic circulation. One common manifestation of this is jugular venous distension, where the jugular vein that's relatively close to the heart becomes enlarged and distended. One fact that you have to remember here is that normally, during inspiration, the jugular venous pressure falls because blood returns to the right ventricle. However, in constrictive pericarditis, the right ventricle isn't as compliant. So in this case, during inspiration, the jugular venous pressure will paradoxically rise, and this is called Kussmaul's sign. Also in the body, when blood backs up to the liver and portal circulation, it causes hepatomegaly, or liver distension, as well as portal hypertension and ascites, which is the accumulation of fluid in the peritoneal cavity. Finally, fluid that backs up into the interstitial space in the soft tissues of the legs causes pitting edema, which means that the tissue is visibly swollen. And when you apply pressure to it, it leaves a pit and takes a while to come back to its original place. The main symptom of pericarditis, which is extremely high yield, is severe, sharp retrosternal chest pain that radiates to the neck, shoulders, and back, and it typically happens with each breath during inspiration. That's because the lungs expand during inspiration, filling the thoracic cavity and compressing the pericardium. The pain typically worsens when a person is supine and improves when a person is sitting upright and leaning forward, because less pressure is put on the heart. For diagnosis, the most important clue is that upon auscultation, there's a pericardial friction rub, which is a scratchy, grating, high-pitched rub resembling the sound of leather rubbing against leather. On ECG, there's widespread ST segment elevation in several leads. This will help you distinguish it from the myocardial infarction, which also presents with chest pain and ST elevation. But in myocardial infarction, the ST elevation is only present in the leads that correspond to the infarcted tissue. Also for your tests, remember that PR segment depression is a very specific ECG finding in pericarditis. On imaging, pericarditis can show up as an enlarged heart on chest X-ray, and an echocardiogram can show fluid in the pericardium. In constrictive pericarditis, a CT can detect calcifications and thickening of the pericardium seen in a CT scan. Okay, there's one more thing to talk about, which is cardiac tamponade. Pericarditis can lead to pericardial effusion when fluids begin to pool in the pericardial space, and the serous pericardium can't remove it as quickly as it builds up. In general, cardiac tamponade can result from pretty much anything that causes rapid accumulation of fluid inside the pericardium. For example, a stab wound can puncture a blood vessel and fill the pericardium with blood. Even blunt trauma, like a steering wheel getting pushed into your chest during a car crash, can lead to tamponade, because the force of the impact causes the rupture of lots of small blood vessels. Cardiac tamponade can also classically happen a few days after a myocardial infarction, because the weak infarcted ventricular wall ruptures when it's exposed to the high ventricular pressure. Yet another cause is aortic dissection, which is when blood pools in the actual wall of the aorta. If the aortic dissection ruptures through the wall of the aorta and through the fibrous pericardium, blood can spill right into the pericardial cavity, leading to cardiac tamponade. In any case, when fluid fills the pericardium, it starts putting pressure on the heart itself, preventing it from fully stretching out or relaxing between contractions. This means that the cardiac chambers can't fill with blood properly, causing a decrease in cardiac output, so less blood is squeezed out with each heartbeat, leading to hypotension. In other words, the entry of blood into and out of the heart is obstructed, leading to hypotension, and this is called obstructive shock. To compensate, the heart rate increases. When a person suffering from cardiac tamponade inhales, the systolic blood pressure sometimes drops. The reason behind this is that normally, breathing in creates a tiny bit of negative pressure in the heart, pulling in blood from the vena cavas. This momentarily increases systemic venous return. When that happens, the right heart volume increases, and the right ventricle expands a bit into the pericardial space, so it doesn't affect the left heart volume at all. In cardiac tamponade, during inspiration, the right ventricle can't move into the pericardial space, so the extra volume pushes the intraventricular septum toward the left. This leads to a reduction in left ventricular diastolic volume, a lower stroke volume, and a drop in systolic blood pressure during inspiration. A decrease in the systolic pressure of greater than 10 millimeters of mercury is called pulsus paradoxus. And the high-yield fact here is that it's a classic sign of cardiac tamponade, but can also happen with asthma, obstructive sleep apnea, croup, and pericarditis. In cardiac tamponade, the upper heart chambers are also affected. The atria can't distend enough to accommodate the venous blood returning to the heart. That blood will have nowhere to go but back into the veins. That's why you'll typically see distended jugular veins and Kussmaul sign when you look at the neck of a person with cardiac tamponade. This is actually part of a triad of symptoms called the Beck's triad, which includes distended neck veins, hypotension, and distant heart sounds on auscultation. The last one happens because the fluid buildup muffles the normal heart sounds. In cardiac tamponade, classic findings on the ECG include tachycardia, a low QRS complex, and electrical alternans, which is when the QRS complexes have different heights. This happens because the heart moves abnormally within the pericardial cavity, which leads to strange reading in the electrodes. Cardiac catheterization measures the pressure inside the cardiac chamber, and in case of tamponade, the diastolic pressure in all four chambers are equal. For your exams, it's important to differentiate cardiac tamponade from tension pneumothorax. Pneumothorax means that there's air in the pleural space. This is often caused by injury to the lung or damage to the pleura, which can form a one-way valve, allowing air to go in, but not to go out. The air builds up in the pleural space, causing it to expand and compress the right atrium of the heart and the vena cava. This decreases venous return and cardiac output, and resulting in hypotension similar to tamponade. Now, what sets it apart is that unlike cardiac tamponade, heart sounds are normal, while breath sounds are decreased or absent in the side of the injury, which is also hyperresonant on percussion. In addition, chest expansion is asymmetrical, and the trachea is deviated away from the affected side. And that shift of the trachea as well as the whole mediastinum will also be visible on a chest X-ray. In terms of treatment, the main goal is to relieve pain and to treat the underlying cause of inflammation. This is done with NSAIDs or glucocorticoids. Colchicine, a medication that inhibits neutrophil migration, is also used to decrease the likelihood of recurrent pericarditis. Constrictive pericarditis may require pericardiectomy, which is a surgical removal of the pericardium. For cardiac tamponade, an emergency pericardiocentesis can be done by inserting a needle into the pericardial cavity and draining the excess fluid. Okay, let's review. Pericarditis is inflammation of the pericardium, and in most cases, it's idiopathic. It can also be caused by viral infections, like a Coxsackie B virus, autoimmune conditions, neoplasia, uremia, radiotherapy, myocardial infarction, and Dressler syndrome. It presents with sharp retrosternal chest pain that gets worse with inspiration and is relieved when sitting up and leaning forward. The important sign to look for is a friction rub, which can be auscultated. ECG changes in pericarditis include ST segment elevation and PR depression. Now, sometimes, when the inflammation persists, immune cells can initiate fibrosis of the serous pericardium, which can produce an inelastic shell around the heart. And this is called constrictive pericarditis. When pericarditis causes fluid to build up in the pericardial cavity, this is called a pericardial effusion. Finally, when there's a lot of fluid in the pericardial cavity, it can put pressure on the heart and lower the cardiac output, and this is called cardiac tamponade. It presents with Beck's triad of hypotension, distended neck veins, and distant heart sounds, as well as with a high heart rate and pulsus paradoxus. ECG in cardiac tamponade shows low voltage QRS complexes, as well as electrical alternans. Back to our cases. Pamela came in with sharp retrosternal chest pain that gets worse with inspiration, and a friction rub has been heard. Both the symptoms and the physical findings are classic clues for pericarditis. The ECG showed ST elevation and PR depression, and if an echocardiogram is done, it will detect fluid around the heart. This means that Pamela has acute pericarditis. Thomas came in with severe hypotension, distended neck veins, and distant heart sounds, which are the three signs in Beck's triad. His heart rate was high to compensate for the decreased cardiac output and the ECG showed low voltage QRS complexes. So he's got a bad case of cardiac tamponade.
Melissa is a 21-year-old college student who's having the time of her life at a party. It's late, and unfortunately, she has class the next morning, so she drinks a ton of coffee to sober up. On her way out, Melissa collapses to the floor, but wakes up after a couple of seconds. On her way to the emergency room, she tells the paramedics that she's aware of her heartbeat. Then comes Taylor, a 32-year-old female who is brought to the emergency room by her partner because she suddenly collapsed for a couple of minutes while cooking dinner. Taylor's now awake, and she tells you that right before collapsing, she was feeling dizzy and like her heart was racing, but now she's fine. They're both placed on different monitors. Melissa's heart rate is 200 beats per minute and regular, and this is Melissa's ECG. On the other hand, Taylor's heart rate is 80 beats per minute and regular, so everything seems fine. However, her ECG shows this. Alright, so both Melissa and Taylor have experienced palpitations and syncope, and their ECGs reveal they both have some form of arrhythmia. The best way to approach arrhythmias is to first know what a normal ECG looks like, and second, have a good classification system to narrow down the diagnosis. First, let's review the normal electrical conduction pathway in the heart and how it looks on an ECG. An ECG tracing specifically shows how the depolarization wave flows through the heart during each heartbeat. The normal electrical activity of the heart starts in the sinoatrial or SA node and is then conducted through the atrium, creating the P wave on ECG. From the atrium, electrical activity goes to the atrioventricular or AV node, after which it goes through the bundle of His. Then, the right and left branches of the bundle, and finally, through the Purkinje fibers, which deliver the current to the right and left ventricles. On an ECG, this will create the QRS complex, which represents the depolarization of the ventricles, and finally, the T wave, which represents the repolarization of the ventricles. To help identify an irregular rhythm, you can look at the morphology of the waveform, and make sure that there is a P wave before every QRS complex and a QRS complex after every P wave. Now let's take a look at the heart rate. The resting heart beats at a rate between 60 to 100 times per minute, and each of those beats starts off with depolarization of the sinoatrial node, and so we call it a normal sinus rhythm. For your exams, you should be able to figure out the heart rate on an ECG. To do that, you can count the number of boxes between R waves. Each small box represents 0.04 seconds, and each big box is 5 small boxes, so each big box is 0.2 seconds. One quick way to estimate the heart rate on an ECG is to remember that the heart rate is 300, 150, 100, 75, 60, or 50, depending on whether there's 1, 2, 3, 4, 5, or 6 boxes between R waves. It's important to know that there is normally a delay in conduction at the AV node and the bundle of His, which gives some time for ventricular filling before the ventricle contracts. On the ECG, this is represented by the PR interval, which should be less than 5 small boxes, or 200 milliseconds. Now, any disturbance in the rate, rhythm, site of origin, or conduction of the cardiac electrical activity is called an arrhythmia. Arrhythmias can be completely asymptomatic and be picked up incidentally on an ECG. Arrhythmias can also present with palpitations, which is an awareness of one's heartbeat. Additionally, they may alter cardiac output, causing individuals to present with signs of hypotension and decreased brain perfusion, like dizziness, altered mental status, or syncope. If an arrhythmia is really fast, the heart now demands more oxygen, and if oxygen supply is not met, then the myocardium suffers from ischemia, which presents as angina. In people with underlying heart disease, the sudden onset of an arrhythmia can precipitate acute heart failure. Finally, some arrhythmias may even cause sudden cardiac death. Now, arrhythmias can be classified into those originating from above the ventricles, so supraventricular arrhythmias, and those originating in the ventricles, so ventricular arrhythmias. In general, what's important to remember is that supraventricular arrhythmias have a narrow QRS complex because there's a rapid excitation of the ventricles, which means the arrhythmia is originating above or within the bundle of His. On the other hand, ventricular arrhythmias have a wide QRS complex because there's a slower spread of ventricular depolarization. The first type of supraventricular arrhythmia includes those with sinus origin. So first, there's sinus tachycardia, which is a heart rate above 100 with a regular rhythm and normal P waves before each QRS complex. It can be physiological, like during exercise, or pathological. Pathological sinus tachycardia happens when the heart needs to compensate for an acute decrease in stroke volume, like in acute heart failure, acute myocardial infarction, or pulmonary embolism. It can also result from any overwhelming activation of the sympathetic nervous system, like in hyperthyroidism or cocaine or amphetamine use. Now, the thing is that a fast heart rate decreases diastolic filling time, which actually further decreases the stroke volume. Additionally, over time, catecholamines are actually toxic to the myocytes, which results in a form of cardiomyopathy called tachycardia-induced cardiomyopathy, which is a super creative name. Okay, but on the other hand of the spectrum, we have sinus bradycardia. Keep in mind that this can be completely physiological in athletes who have a resting heart rate between 40 and 60, and it's also normal during sleep. Pathological causes of sinus bradycardia include hypothyroidism, anorexia nervosa, and inferior wall myocardial infarctions. Another high-yield cause of bradycardia is the Cushing reflex, which includes the characteristic triad of bradycardia, hypertension, and an irregular respiratory pattern. This reflex occurs as a consequence of increased intracranial pressure, which can manifest from a variety of pathologies, like head trauma, strokes, and brain tumors. For your exams, note that Cushing triad may indicate impending brain herniation, and thus it is a medical emergency. Other causes of sinus bradycardia include a bunch of medications like beta blockers, calcium channel blockers, and opiates, in which case the solution is discontinuing the medication if possible. Acute sinus bradycardia can be treated with IV atropine, while chronic and severe cases might need a pacemaker. Another arrhythmia of sinus origin is, sinus arrhythmia. This arrhythmia can occur naturally during inspiration and expiration. See, during inspiration, the heart rate increases, and during expiration, it decreases. So on ECG, the rhythm may appear irregular, but it is in fact a normal variant. Finally, sinus arrest, or sinus exit block, occur when the sinus node fails to fire. What you need to know is that on an ECG, there is simply a flatline pause. Fortunately, if the sinus node can't press that reset button, somebody else, like the AV node or virtually any other myocardial cell, can take over. All right, now the second type of supraventricular arrhythmias are reentrant arrhythmias. In this type, electrical activity is literally trapped in a circular electric racetrack, altering normal conduction. To understand this, let's picture a single myocyte with two branches, triggering two adjoining pathways, 1 and 2. Under normal circumstances, electrical activity starts on the SA node and then travels from one myocyte to the other. Now, the wave of depolarization should go through both 1 and 2 at the same speed. But let's say pathway 2 was damaged during a myocardial infarction. Now that pathway 2 is slowed down, the wave of depolarization rushes through pathway 1 and then returns backwards through pathway 2. This creates an electrical loop that is now independent of the SA node, meaning it can pretty much run itself now. There are 3 must-know subtypes of reentrant supraventricular arrhythmias: paroxysmal supraventricular tachycardia, or PSVT, atrial flutter, and atrial fibrillation. PSVT is usually caused by a re-entrant circuit that loops within the AV node, which is why it's also referred to as an AV nodal re-entrant tachycardia. PSVT can happen in people with totally normal hearts and no history of cardiac disease. A clue to this can be recent consumption of things like alcohol and coffee. On the ECG, PSVT appears as a regular rhythm with a rate ranging between 150 and 250 beats per minute, and a narrow QRS complex. The key is the absence of normal P waves, which tells us that the SA node is no longer in control. Now, the re-entrant circuit is within the AV node, meaning it can go from the AV node up towards the atria. Since it's going in the opposite direction, you may be able to see retrograde P waves. However, because the PSVT is super fast, these retrograde P waves are usually buried in the QRS complex, so you may or may not see them. PSVTs are classically treated with vagal maneuvers, like carotid massage. When the carotid artery is massaged, the carotid sinus is stimulated, which stimulates the vagus nerve to fire. This slows conduction through the AV node, which interrupts the reentrant circuit, effectively slowing the heart rate and terminating the arrhythmia. Now, if vagal maneuvers don't work, the next step for treatment is adenosine, and this is commonly tested. Adenosine rapidly acts in about 15 seconds, causing a decrease in AV node conduction. Keep in mind that its effect is blunted by theophylline and caffeine. Another important thing to remember are its side effects, which include facial flushing, hypotension, bronchospasm, and chest pain. Moving on, atrial flutter is usually caused by a re-entrant circuit that runs around the annulus of the tricuspid valve. On ECG, this usually appears as a regular rhythm with an atrial heart rate ranging between 250 and 350 beats per minute. Now, because of this super fast atrial heart rate, the AV node cannot handle all these impulses coming at it, so some impulses get through, and some don't. This generates what's called an atrial-ventricular conduction ratio, which is usually 2:1, meaning one impulse gets through to the ventricles and the next does not, and so on. So let's say the atrial heart rate is 300. The ventricular rate would then be 150. The AV conduction ratio can be 3:1 or even 4:1. Okay, so on ECG, the giveaway will be flutter waves, which are P waves that give off a sawtooth appearance. Now, because the re-entrant circuit is not within the AV node like in PSVT, vagal maneuvers will not work here, simply because the vagus nerve isn't innervating where the arrhythmia started. Instead, medications or electrical cardioversion is required to keep atrial flutter under control, while definitive treatment can be done with catheter ablation. Okay, so in atrial flutter, there was a single reentrant circuit causing the problem. On the other hand, in atrial fibrillation, there are hundreds of reentrant circuits scattered around the atria. The most common risk factors are hypertension and coronary artery disease. Another interesting cause is the holiday heart syndrome, where atrial fibrillation occurs after binge drinking. Now, for your exams, remember that here, the atrial heart rate is really fast, going above 500 beats per minute. So on the ECG, no P waves are seen. The poor AV node is seriously overwhelmed now, so we don't even get an AV conduction ratio. Instead, the AV node allows impulses to pass in a random and unpredictable fashion. On the ECG, this typically appears as an irregularly irregular rhythm, which means the QRS complexes will have no pattern at all, with a ventricular rate usually ranging between 120 and 180 beats per minute. The name fibrillation implies that the atrial muscles are shaking uncontrollably, meaning there is no actual atrial contraction. Now, atrial contraction only contributes to about 10 to 20% of the cardiac output, but in an individual with a history of cardiac disease, that 20% might be crucial. Another high-yield fact is that the absence of a true contraction causes stasis of blood flow in the atrial compartment, and this increases the risk of clot formation, especially in the left atrial appendage. This clot can dislodge and travel into the systemic circulation, causing multiple potentially life-threatening pathologies like embolic strokes, acute limb ischemia, central retinal artery occlusion, or acute mesenteric ischemia. Therefore, individuals often need treatment with anticoagulants, in addition to treating the arrhythmia itself with medications like beta blockers and calcium channel blockers. Finally, some individuals can be treated with cardioversion. A third type of supraventricular arrhythmia is ectopic rhythms, in which electrical activity may originate from a place other than the sinus node. Basically, fastest one to fire gets to be the pacemaker of the heart. If any myocardial cell gets a bit ambitious and starts firing faster than the SA node, then it can overtake the SA node as the pacemaker of the heart. A type of supraventricular arrhythmia with ectopic origin is multifocal atrial tachycardia, or MAT, which usually results from multiple ectopic foci firing from the atrium. MAT is classically associated with lung disease like asthma or COPD, so be sure to look for that in the question stem. On ECG, this also appears as an irregular rhythm at a rate of around 100 to 200 beats per minute. However, unlike atrial fibrillation, P waves are present in MAT. But because the P waves are originating from multiple sites in the atrium, they often vary in shape, and so will the PR intervals. In order to diagnose MAT, you need to identify at least 3 different P wave morphologies on ECG. Now, before we wrap things up, we should talk about pre-excitation syndromes, which may ultimately lead to supraventricular arrhythmias, especially PSVT. In pre-excitation syndromes, there's an accessory pathway that acts as a shortcut to the normal electrical circuit, causing the ventricles to be excited earlier than usual. The most important pre-excitation syndrome is Wolff-Parkinson-White syndrome, or WPW. People with WPW are born with an additional conduction pathway between the atria and the ventricles called the bundle of Kent. The cause of WPW is most often unknown, whereas a few cases are inherited through an autosomal dominant mutation of the PRKAG2 gene, which helps regulate ion channels specific to cardiac tissue. The 3 major changes on ECG in WPW are shortening of the PR interval, widening of the QRS complex, and presence of a delta wave, which is an upward slurring of the initial portion of the QRS complex. The delta wave indicates that the ventricle is being activated earlier than it normally should. Now, most people remain asymptomatic despite having this classic ECG pattern, whereas a small number can develop arrhythmias that can manifest as palpitations, dizziness, syncope, and even sudden cardiac death. All right, as a quick recap, an arrhythmia is any disturbance in the rate, rhythm, site of origin, or conduction of the cardiac electrical impulse. Arrhythmias can be classified based on their origin into supraventricular arrhythmias, which have a narrow QRS complex, or ventricular arrhythmias, which have a wide QRS complex. Supraventricular arrhythmias can be of sinus origin. This includes sinus tachycardia, which is a heart rate above 100, with a regular rhythm and normal P waves before each QRS complex, and sinus arrhythmia, which is a normal phenomenon that reflects the changes in heart rate during inspiration and expiration. Supraventricular arrhythmias can also have a reentrant origin. This includes PSVT, a regular rhythm with a narrow QRS complex and an absence of normal P waves, atrial flutter, a regular rhythm with P waves that give off a sawtooth appearance, and atrial fibrillation, an irregular rhythm with no P waves. Finally, supraventricular arrhythmias can have an ectopic origin like multifocal atrial tachycardia, which is an irregular rhythm with present P waves. An important cause of supraventricular arrhythmias are pre-excitation syndromes, like Wolff-Parkinson-White syndrome, in which an accessory pathway acts as a shortcut that causes the ventricles to be excited earlier than usual. Okay, back to our cases. Both Melissa and Taylor's presentations describe syncope and palpitations, suggesting something is going on with their hearts. Based on Melissa's ECG, this is likely a paroxysmal supraventricular tachycardia, or PSVT. In her case, it was likely triggered by her consumption of alcohol and caffeine. After a carotid massage is performed, her ECG converts back to a normal sinus rhythm. On the other hand, Taylor's ECG shows a short PR interval and a wide QRS complex with an initial delta wave, which is the classic ECG pattern of Wolff-Parkinson-White syndrome. Valvular heart disease involves damage or a defect in one or more of the four valves of the heart. So the aortic and bicuspid or mitral valves on the left side of the heart, and the pulmonary and tricuspid valves on the right side of the heart. Normally, the valvular leaflets are very thin, and when the cusps close, they're perfectly opposed. Valvular heart diseases are divided into stenosis, in which there's a narrowing of the valvular orifice that prevents adequate outflow of blood, and insufficiency or regurgitation, in which the valvular leaflets fail to close correctly and are unable to prevent backflow of blood. These two are not mutually exclusive, which means they can both be present in the same individual and even in the same valve. For instance, if thickening of the leaflets results in inappropriate closure as well as a narrow orifice. Individuals with valvular heart disease are generally asymptomatic for a prolonged period, even for decades, and as soon as they become symptomatic, their life expectancy deteriorates very quickly. The main symptoms are dyspnea, syncope, and angina. Both stenosis and regurgitation lead to turbulent flow when blood flows across the affected valve, which produces heart sounds called pathologic murmurs that are loud enough to be heard upon auscultation with a stethoscope. When presentation suggests valvular heart disease, you should proceed with echocardiography to confirm the diagnosis of valvular disease and determine its severity. A transthoracic echocardiogram is typically done, but a transesophageal echocardiogram may be needed in selected individuals, like those with a non-diagnostic transthoracic echocardiogram. Doppler echocardiography allows determination of the speed and direction of blood flow, which makes it the most sensitive non-invasive technique for detecting the regurgitant jet. In some cases, cardiovascular magnetic resonance imaging may be indicated to quantify the severity, measure left ventricular diastolic and systolic volumes, and assess left ventricular systolic function. And as a last resort, cardiac catheterization is indicated when non-invasive tests are inconclusive or provide discrepant results, or for coronary angiography prior to valve surgery in patients at risk for coronary disease. Cardiac catheterization allows you to measure pressure waveforms, which are indirect measurements of the left atrial pressure. Alright, on to aortic stenosis, which is the most common cause of valvular heart disease. Typically, the three leaflets of the aortic valve get thick and calcified and don't open all the way, making it harder to pump blood out of the body. Most often, the aortic valve is tricuspid, but in some people, it may be unicuspid, bicuspid, or quadricuspid. Valves with a different number of cusps than tricuspid degenerate much more easily. Valve degeneration is usually due to wear and tear and atherosclerosis, so these patients tend to be older. In aortic stenosis, the pulse is described as being parvus and tardus. That's because the valve doesn't fully open, so there's less blood flow, and the pulse is weak, parvus. And there's a delay in the opening of the valve, which causes a mid-systolic crescendo-decrescendo murmur that occurs a bit later than expected in systole, tardus. This murmur mirrors the ejection of blood from the ventricle into the aorta. It increases with increasing pressure of ejection and decreases as ejection pressure decreases. In aortic stenosis, thicker leaflets due to calcification are usually visible, as calcium on echo is bright white, and the opening of the valve is also greatly reduced. Doppler echocardiography permits measurement of jet velocity of blood and calculation of the left ventricular aortic gradient and the valve area, which are the standard parameters used for evaluation of stenosis severity. The flow is very turbulent because of the stenotic valve, presenting as elevated jet velocity. Blood pressure gradient is useful to understand the severity of the stenosis. Usually, the cutoff is a mean gradient higher than 40 millimeters of mercury. The more severe the aortic stenosis, the higher the blood pressure gradient. Asymptomatic individuals aren't treated, while symptomatic aortic stenosis is an indication for aortic valve replacement, choosing from manufactured mechanical valves, human donor valves, or tissue valves created from animal tissue. Aortic valve replacement can be done either through open heart surgery with surgical aortic valve replacement, or SAVR, or through transcatheter aortic valve implantation, or TAVI, which involves placing the valve through a catheter, typically through the transfemoral route in the upper leg. SAVR and TAVI should be used in individuals who are likely to have a prolonged life expectancy of at least a year, as well as an improved quality of life. For those individuals, the benefits should be weighed against the risk of the procedure. For individuals with low surgical risk, or if transfemoral TAVI is not feasible, SAVR is performed. For individuals with intermediate or high surgical risk, or if SAVR is contraindicated, then TAVI is performed. Medical therapy has limited utility in treating aortic stenosis, so it's given as a last resort to individuals that are not candidates for aortic valve replacement. The medications used include digoxin, diuretics, ACE inhibitors, or angiotensin receptor blockers. Now, in aortic regurgitation, the valve doesn't close all the way during diastole, and blood leaks back from the aorta into the left ventricle. That leads to progressive ventricular dilation to accommodate the increased blood volume. The valve leaflets may be abnormal or may be normal but stretched apart due to dilation of the ascending aorta. Abnormalities that may be seen include thickening, vegetations, calcification, and prolapsed or flail leaflets. On physical examination, aortic regurgitation causes a collapsing pulse or water hammer pulse. To feel it, the individual must lie back and raise their arm vertically upward, and the examiner has to grasp the muscular part of the patient's forearm. A water hammer pulse is felt as a tapping impulse that's felt through the bulk of the muscles, because the blood that is pumped to the arm during systole is emptied back into the heart during diastole due to the effect of gravity on the raised arm. Upon auscultation, there's an early diastolic murmur due to the backflow, and since there's more volume in the left ventricle when it contracts, there's also an ejection systolic murmur. The severity of aortic regurgitation is determined through echocardiography or cardiac magnetic resonance imaging, which specifically look at the volume of blood flowing back into the left ventricle with each beat. The mainstay of treatment is aortic valve surgery, which is indicated in severe aortic regurgitation. But if aortic regurgitation is not severe, or even if it's severe but doesn't cause left ventricular dysfunction, then surgery isn't recommended. Instead, the individual is given medications like ACE inhibitors, angiotensin receptor blockers, or vasodilators if they have hypertension. Now, if there's severe aortic regurgitation and left ventricle impairment, and if the surgical risk is low, then aortic valve surgery is recommended. Alternatively, if individuals have another indication for cardiac surgery, like concomitant disease of another valve, then aortic valve surgery may be done independently of severity. Moving on to mitral regurgitation, it's caused by imperfect closure of the mitral valve during systole, which causes backflow of blood from the left ventricle into the left atrium. This volume overload leads to an increase in left atrium pressure, which can cause pulmonary hypertension due to backward pressure transmission, and eventually leads to atrial dilation. When that happens, the muscle walls stretch and the pacemaker cells that run through the walls become more irritable, increasing the risk of atrial fibrillation. And atrial fibrillation can lead to blood stagnation and thrombus formation, which can then flow into the systemic circulation, potentially leading to a stroke. Upon auscultation, a pansystolic murmur can be heard. Mitral regurgitation is classified as either primary when it's due to valve damage or abnormality, or secondary or functional when it's due to a ventricular dysfunction or abnormality that causes valvular dysfunction without damage to the valve itself, such as left ventricular dysfunction or dilation. For individuals with or without symptoms that have primary mitral regurgitation, the definitive treatment is valve replacement. But valve replacement comes with an increased risk of thrombosis, embolism, and endocarditis, so the decision has to be carefully weighed out. When mitral valve replacement is required, a choice is made between a mechanical or bioprosthetic valve. Mechanical valves have the disadvantage of requiring lifelong anticoagulation therapy with warfarin, while bioprosthetic valves have the disadvantage of limited durability due to valve degeneration, and that's particularly relevant in individuals under the age of 65. Now, if the valve is not too damaged, then mitral valve repair is preferred to mitral valve replacement. And the valve repair can be done either through open heart surgery or as a transcatheter mitral valve repair. And for those who can't undergo repair or replacement, medical therapy with diuretics, digoxin, and ACE inhibitors is typically done. But medical therapy helps to alleviate the symptoms, and it doesn't stop disease progression. In case of mitral stenosis, the leaflets can fuse together, so the mitral valve doesn't open enough. This makes it a lot harder for blood to flow from the left atrium to left ventricle, leading to higher pressures in the left atrium. To compensate for the increased resistance of the valve, there's left atrial hypertrophy and dilation. A constant elevation in both blood volume and pressure in the left atrium causes it to dilate and can allow blood to back up into the pulmonary circulation, causing pulmonary congestion and pulmonary edema. All this extra blood volume in the pulmonary circulation causes pulmonary hypertension, which can ultimately make it harder for the right ventricle to pump blood to the lungs. And over time, the right ventricle can hypertrophy and ultimately fail, which is called right-sided heart failure. A typical feature of mitral stenosis is the strong pulsation that is seen in the left part of the heart due to stenosis during the second heart sound in diastole. On auscultation, mitral stenosis causes a low-pitched, mid to late diastolic murmur. On echocardiography, there's left atrial enlargement, thick and calcified mitral valve with narrow orifice, and increased blood flow velocity during diastole. The transmitral pressure gradient, as measured by Doppler echocardiography, is the gold standard for diagnosis, allowing classification of mitral stenosis as mild if lower than 5 millimeters of mercury, moderate if between 5 millimeters of mercury and 10 millimeters of mercury, and severe if higher than 10 millimeters of mercury. The most common cause of mitral stenosis is rheumatic fever, mainly affecting children and young adults in developing countries. The treatment options for mitral stenosis include mitral valve replacement by surgery and percutaneous mitral valvuloplasty, which is a minimally invasive therapeutic procedure that opens the orifice by dilating the valve using a balloon. Determining which patients would benefit from percutaneous mitral valvuloplasty relies on 4 echocardiographic criteria: leaflet mobility, leaflet thickening, subvalvular thickening, and calcification. Treatment is chosen based on the presence of symptoms. In asymptomatic individuals with a low risk of thrombosis, percutaneous mitral valvuloplasty is done. If there are contraindications for percutaneous mitral valvuloplasty, the individual will be followed up for at least 6 months. In symptomatic cases of mitral stenosis, percutaneous mitral valvuloplasty is performed, and if there are contraindications, then open surgery is recommended. Alright, on to the tricuspid valve. Tricuspid regurgitation occurs when the valve can't close adequately, resulting in the backward leakage of blood from the right ventricle into the right atrium with each heartbeat. And tricuspid stenosis is an extremely rare condition in which the valve may become stiff and narrowed, impairing the forward flow of blood from the atrium to the ventricle. Tricuspid valve diseases, so both regurgitation and stenosis, typically don't cause symptoms until they become severe, and they eventually lead to an increased pressure in the right atrium. Symptomatic individuals might have distended neck veins, swelling of the ankles and feet, and hepatosplenomegaly, reflecting the backflow of blood from the right side of the heart. Treatment aims at maintaining good fluid balance by giving medications like diuretics. Tricuspid valve surgery is only indicated in rare, severely symptomatic cases, or in those already getting surgery for another heart condition. Finally, there's the pulmonary valve. Pulmonary stenosis makes it harder for the heart to pump blood to the lungs, and that causes symptoms like cyanosis, dyspnea, and fatigue, which are most noticeable during exercise. Pulmonary stenosis is generally congenital, but unless the degree of stenosis is severe, individuals with pulmonary stenosis usually don't require intervention until later in adulthood. Treatment of pulmonary valve stenosis usually involves a balloon valvuloplasty, which means that a balloon is inserted and then inflated to open the narrowed valve and allow more blood flow through it. On the other hand, in pulmonary valve regurgitation, blood leaks back into the right ventricle. Over time, pulmonary valve regurgitation can lead to right-sided heart failure, which can cause the blood to back up, and symptoms like distended neck veins, swelling of the ankles and feet, and hepatosplenomegaly. Treatment for pulmonary regurgitation is usually valve repair or replacement if right-sided heart failure develops. Alright, as a quick recap. Aortic stenosis presents with parvus and tardus, mid-systolic crescendo-decrescendo murmur, and a higher blood gradient. The blood pressure gradient cutoff is a mean gradient higher than 40 millimeters of mercury, and the more severe the aortic stenosis, the higher the blood pressure gradient. Aortic regurgitation presents a collapsing pulse, or water hammer pulse, an early diastolic murmur, and an ejection systolic murmur. Mitral regurgitation presents a pansystolic murmur, while mitral stenosis presents a mid to late diastolic murmur, but both cause pulmonary hypertension. The transmitral pressure gradient allows classification of mitral stenosis as mild if lower than 5 millimeters of mercury, moderate if between 5 and 10, and severe if higher than 10. Tricuspid and pulmonary valve disease mainly cause leg swelling, hepatomegaly, and distended neck veins. Echocardiography is then performed to confirm diagnosis of valvular heart disease, as well as an evaluation of severity and treatment choice. Treatment generally involves either valvular repair or replacement.
On the cardiology ward, there are two individuals. One of them is 75-year-old Antonia, who is complaining of chest pain and says she hardly catches her breath after walking. On clinical examination, her pulse feels pretty weak, and on auscultation, a systolic murmur is heard. The murmur was louder just after S1 and got quieter and quieter by the end of S2. The other individual is 38-year-old Mark, who has a history of rheumatic fever and is complaining of not being able to swallow properly. On clinical examination, his voice sounds raspy, and on auscultation, a snap is heard after S2 along with a diastolic rumble. Based on auscultation, both individuals were sent for echocardiography. Okay, so based on auscultation and symptoms, both individuals seem to have valvular heart disease. Valvular heart disease involves damage or a defect in one or more of the four valves of the heart, so the aortic and mitral valves on the left side of the heart, and the pulmonary and tricuspid valves on the right side of the heart. Okay, now before talking specifics about valvular disease, we'll first talk about rheumatic fever, which can affect multiple valves. Rheumatic fever can develop after streptococcal infection like strep throat, which is caused by Streptococcus pyogenes. This particular group of Streptococcus has an antigen that lumps it into a group called Group A, and they also produce an enzyme called streptolysin, which causes hemolysis. Some of these strep bacteria have a protein on their cell wall called M protein, and this particular protein is highly antigenic, meaning that the immune system sees it and recognizes it as a foreign molecule and produces antibodies against it. Now, this becomes a problem when these antigens cause a phenomenon called molecular mimicry. M proteins can be structurally similar to human proteins, which means the antibodies that target them will also target our own tissue. In this case, they're similar to proteins found in the myocardium and heart valves. Once bound to cardiac tissue, the antibodies activate nearby immune cells, which causes a cytokine-mediated inflammatory response and tissue destruction. This is also an example of what's called a type 2 hypersensitivity reaction. Alright, so not everyone that gets strep throat gets rheumatic fever, and it's actually only a small minority that get it. However, the individuals that do get rheumatic fever from strep infections will have a variety of clinical findings. These make up the Jones criteria, which is divided into 5 major criteria that you have to remember, and 5 minor criteria that are also good to keep in mind. Let's go over the major criteria first. The most common is migratory polyarthritis of the joints, where multiple large joints become inflamed, swollen, and painful, then the inflammation resolves and spreads to other joints. Secondly, some patients have carditis. The inflammation can affect the endo, myo, and pericardium. Since the endocardium involves the valves, they too are affected. A high-yield fact to remember is that the mitral valve is most commonly affected, although the aortic and tricuspid valve can also be affected. In the acute phase of the illness, mitral regurgitation is most common. Later on, fibrosis around the valve causes its leaflets to fuse together, giving it a fish mouth-like appearance. This fusion narrows the valve opening, and so we get mitral stenosis. Now, although not a part of the Jones criteria, a high-yield fact is that on histology there will be Aschoff bodies in the heart. These are granulomas with giant cells, consisting of areas of fibrinoid necrosis and lymphocytic infiltration. Within Aschoff bodies, there are characteristic Anichgau cells, which are enlarged macrophages that have a characteristic caterpillar-looking nucleus. Now for the rest of the Jones criteria, the hypersensitivity reaction in rheumatic fever can affect the skin. So the next criteria is subcutaneous nodules, which are these firm lumps under the skin made up of collagen. The fourth is erythema marginatum, a reddish rash that shows up as rings on the arms or trunk. And finally, there's Sydenham's chorea, which is a set of rapid movements of the face and the arms caused by an autoimmune reaction against the basal ganglia of the brain. For the minor criteria, there's polyarthralgia, fever greater or equal to 38.5 degrees Celsius, blood tests showing an ESR greater or equal to 60 millimeters per hour, or a CRP greater or equal to 3 milligrams per deciliter, prolonged PR interval, and a blood test that shows evidence of previous streptococcal infection, such as high titers of antistreptolysin O, or ASO. Treatment and prophylaxis of rheumatic fever is done using penicillin. Okay, now let's look at the specific valvular heart diseases. They can be divided into stenosis, where there's narrowing of the valvular orifice that prevents adequate outflow of blood, and insufficiency or regurgitation, where the valvular leaflets fail to close correctly and are unable to prevent backflow of blood. In order to make things easier to remember, we'll classify valvular heart disease based on what type of murmurs you hear on auscultation. Remember, there are 2 normal heart sounds. S1, caused by the mitral and tricuspid valves closing at the beginning of systole, and S2, caused by the aortic and pulmonary valves closing at the beginning of diastole. So first, there are systolic murmurs, which you can hear right after S1, and these happen with aortic stenosis and mitral and tricuspid valve regurgitation. Then there are diastolic murmurs, which come right after S2, and these happen with aortic regurgitation and mitral stenosis. Let's start with systolic murmurs and look at aortic stenosis. The aortic valve is typically made up of 3 leaflets, the right, left, and posterior leaflet, and it opens during systole to allow blood to be ejected to the body. During diastole, it closes to allow the heart to fill with blood and get ready for the next systole. Aortic stenosis is when the aortic valve doesn't open all the way, and it gets harder to pump blood into the aorta. Aortic stenosis is usually caused by chronic mechanical stress that damages endothelial cells around the valves, causing fibrosis and calcification, which hardens the valve and makes it more difficult to open completely. This type usually shows up in late adulthood, so for your exams, remember that this is more common in individuals over 60 years old. Now, if there's aortic stenosis in a younger individual, the cause could be due to a bicuspid valve. These abnormal valves are more at risk of fibrosis and calcification since the mechanical stress is now being split by just 2 leaflets. Okay, let's go over auscultation now. With aortic stenosis, since blood has to flow through a narrow aortic valve, there's turbulence, which creates noise or a murmur. This initially gets louder as more blood flows past the opening and then quieter as the amount of blood flowing subsides. This is called a crescendo-decrescendo murmur, and you can hear this right after S1. This sound is best heard in the aortic area and typically radiates to the carotids. The intensity of the murmur increases as the pressure gradient between the left ventricle and the aorta increases. So the narrower the stenosis, the louder the murmur. Now, normally, S2 has 2 components, the aortic component and the pulmonary component, since the valves don't close at the same time. Typically, the aortic valve closes first, then the pulmonary valve. But with aortic stenosis, the aortic valve closes later than expected, and so it may close at the same time with the pulmonary valve, in which case you'll hear a soft S2. Another important clue that will likely show up on your exam is the ejection click. Since the valve fuses together or hardens, it doesn't open as easily. And so, as the left ventricle contracts, it creates this high pressure that eventually pushes on the valve until it finally snaps open, causing a clicking sound. In aortic stenosis, the pulse is described as being parvus and tardus. That's because the valve doesn't fully open, so there's less blood flow and the pulse is weak, or parvus. And there's a delay in the opening of the valve that occurs a bit later than expected, so the pulse is also late, or tardus. Even though the ventricle tries to pump out more blood, the heart still might struggle to get enough blood through the narrowed opening and then to the rest of the body. For example, if there's a reduction in blood flow to the brain, it could lead to syncope, and a reduction in blood flow through the coronary arteries to the heart's own myocardium could cause chest pain and angina. Individuals might not initially experience symptoms at rest, and problems only occur during exercise or exertion because there's an increase in demand for oxygen. So, during exercise, they can also experience dyspnea. The next systolic murmur is caused by mitral regurgitation. The mitral valve has 2 leaflets, the anterior and posterior leaflet, and together they separate the left atrium from the left ventricle. During systole, the valve closes, which means blood has just one option, to be ejected out through the aortic valve and into circulation. Mitral regurgitation is when the mitral valve doesn't shut all the way, therefore blood can leak back into the left atrium. The leading cause of mitral valve regurgitation in the United States, and the most common of all valvular conditions, is mitral valve prolapse. Normally, when the left ventricle contracts during systole, a ton of pressure is generated to pump blood out through the aortic valve. This also means a lot of pressure pushes on that closed mitral valve. Normally, the papillary muscles and connective tissue, called chordae tendineae, keep the valve from prolapsing or falling back into the atrium. However, sometimes there's myxomatous degeneration, where connective tissue of the leaflets and surrounding tissue are weakened. Why this happens isn't well understood, but it's sometimes associated with connective tissue disorders like Marfan syndrome and Ehlers-Danlos syndrome. Mitral valve prolapse can also be caused by rheumatic fever or by chordae rupture during trauma. Regarding auscultation, mitral valve prolapse also has a classic heart murmur that you have to know for your tests. This includes a mid-systolic click, meaning it appears between S1 and S2. This click is a result of the leaflet folding into the atrium and being suddenly stopped by the chordae tendineae. If there's mitral regurgitation, the mid-systolic click is sometimes followed by a crescendo systolic murmur that's loudest just before S2 and is best heard over the apex. Mitral valve prolapse is often asymptomatic, but it can predispose individuals to infective endocarditis. In addition to mitral valve prolapse, Other causes of mitral regurgitation include damage to the papillary muscles from a myocardial infarction. If these papillary muscles die, they can't anchor the chordae tendineae, which then allows the mitral valve to flop back and allow blood to go from the left ventricle to the left atrium. Also, left-sided heart failure that leads to ventricular dilation can lead to mitral regurgitation as well, because as the left ventricle dilates, it stretches the mitral valve annulus, or ring, wider, and lets blood leak into the left atrium. Mitral regurgitation can also be caused by rheumatic fever or by infective endocarditis without mitral prolapse. Here, chronic inflammation can cause leaflet fibrosis, which makes it so that they can't form a nice seal and instead let blood leak through. Now, the typical auscultation of mitral regurgitation is a hollow systolic murmur, meaning it lasts for the duration of systole, so it's heard between S1 and S2. You may hear this because with mitral regurgitation, blood is flowing back into the left atrium during systole. The sound is a high-pitched, blowing murmur that is loudest at the apex and radiates towards the axilla. Finally, there's tricuspid regurgitation. The tricuspid valve has 3 leaflets, the anterior, posterior, and medial or septal leaflets, and together they separate the right atrium from the right ventricle. During systole, the tricuspid valve closes, and during diastole, the tricuspid valve opens and blood fills the right ventricle. Tricuspid regurgitation happens when the tricuspid valve doesn't close completely and blood leaks back from the right ventricle into the right atrium during systole. Tricuspid regurgitation is most commonly caused by right ventricle dilatation, which in turn can be caused by pulmonary hypertension. Other causes include rheumatic fever. The typical auscultation of tricuspid regurgitation is also a holosystolic, high-pitched blowing murmur, like with mitral regurgitation, but this time is best heard in the tricuspid area. You may hear this because with tricuspid regurgitation, blood flows back into the right atrium during systole. Let's now move on and talk about diastolic murmurs, specifically aortic regurgitation. Normally, right after the ventricle pumps blood out through the aortic valve, the valve shuts and remains shut until the ventricle fills again. With aortic regurgitation, blood flows back from the aorta into the left ventricle during diastole. About half of the cases are caused by aortic root dilation, where the leaflets are also pulled apart, making it harder for the valve to fit together and close all the way, so some blood ends up flowing backwards. Besides aortic root dilation, regurgitation can also happen due to valvular damage from something like rheumatic fever, infective endocarditis, or from a bicuspid aortic valve which doesn't close properly. The typical auscultation in aortic regurgitation is a high-pitched, early decrescendo diastolic murmur, which you can hear right after S2. It's caused by the blood flowing back through the valve. Now, since blood is leaking back from the aorta into the left ventricle, the left ventricular end diastolic volume increases. Because there is a volume overload, the left ventricle responds by undergoing eccentric hypertrophy, which increases the stroke volume or the amount of blood that the left ventricle pumps out during systole. More blood pumped out of the heart per squeeze requires more pressure, so systolic blood pressure increases. However, during diastole, there's less blood volume in the aorta since some has leaked back into the ventricle, which means that diastolic blood pressure decreases. A higher systolic pressure and lower diastolic pressure means an increase in pulse pressure, which is just systolic pressure minus diastolic pressure. A large pulse pressure is referred to as a hyperdynamic circulation. People with hyperdynamic circulation have bounding pulses or water hammer pulses because the blood slams like a hammer against the walls of the arteries with each heartbeat. In chronic and severe cases, these bounding pulses can be dramatic enough that they cause head bobbing that's in tune with the heartbeat. Over time, aortic regurgitation can progress to left heart failure. Finally, there's mitral stenosis, which happens when the mitral valve doesn't open enough. This is highly specific and most often caused by rheumatic fever. In this case, the leaflets can fuse together, which is called commissural fusion. The narrow mitral valve makes it a lot harder for blood to flow from the left atrium to the left ventricle, and so the volume of blood in the left atrium increases, leading to higher pressures in the left atrium. The pressure in the left atrium can be higher than that of the left ventricle. On auscultation, The pressure against the fibrotic mitral valve makes a snap sound when it opens, which you can hear milliseconds after S2. A high-yield concept is that the most reliable indicator of the severity of mitral stenosis is the interval between S2 and the opening snap. The shorter the interval, the more severe the stenosis, because when the pressure in the left atrium gets higher, the snap will happen earlier. Finally, this opening snap is followed by a diastolic rumble, as blood is forced through the smaller opening. This rumble intensifies just before systole because that's when the left atrium contracts against the stenosed mitral valve. In mitral stenosis, the left atrial pressure is increased, and we can measure this by inserting a catheter through the right side of the heart, up the pulmonary artery, and towards the end of it. The catheter then reaches a point at which it cannot cross further. The pressure at this point is called the pulmonary capillary wedge pressure, or PCWP, because the catheter is wedged there. The PCWP closely reflects the left atrial pressure, so in mitral stenosis, the PCWP is increased. Over time, a constant elevation in both blood volume and pressure in the left atrium causes it to dilate. As a consequence, it can compress the esophagus, and patients might have difficulty swallowing solid foods, which is called dysphagia. The dilated left atrium can also compress the left recurrent laryngeal nerve, leading to hoarseness of the voice. Alright, as a quick recap, rheumatic fever is caused by group A beta hemolytic streptococcus. After the initial strep throat infection, some individuals will develop rheumatic fever. The Jones criteria for diagnosing rheumatic fever includes migratory polyarthritis, subcutaneous nodules, erythema marginatum, Sydenham's chorea, and last but not least, carditis. Specifically, rheumatic fever mostly affects the mitral valve, causing stenosis, but can also affect the aortic and tricuspid valves. For the diagnosis, high titers of ASO are also needed. Now, valvular disease can be classified according to the type of murmurs heard on auscultation, systolic and diastolic murmurs. Aortic stenosis, mitral and tricuspid regurgitation cause systolic murmurs, while aortic regurgitation and mitral stenosis cause diastolic murmurs. Aortic stenosis happens when the endothelial cells around the valves undergo fibrosis and calcification. Aortic stenosis has a specific crescendo-decrescendo murmur heard just after S1, and sometimes an ejection click can be heard. Next, there's mitral regurgitation, which is mostly caused by mitral valve prolapse, which is when the connective tissue of the leaflets and surrounding tissue are weakened. On auscultation, mitral valve prolapse often has a mid-systolic click, followed by a crescendo systolic murmur. Mitral regurgitation can also be caused by damage after a myocardial infarction, ventricular dilation, rheumatic fever, or infective endocarditis. On auscultation, mitral regurgitation has a holosystolic murmur best heard over the apex. Now, tricuspid regurgitation is mostly caused by right ventricle dilation and also causes a holosystolic murmur, but this time it's best heard over the tricuspid area. For diastolic murmurs, there's aortic regurgitation, which is mostly caused by aortic root dilation, but can also be caused by infective endocarditis, bicuspid aortic valve, or rheumatic fever. On auscultation, there's a high-pitched, early decrescendo diastolic murmur. There's also an increase in pulse pressure as well as hyperdynamic circulation. Finally, there's mitral stenosis, where on auscultation there's a snap sound after S2 as well as a diastolic rumble as blood is forced through the smaller opening. Okay, back to our cases. Antonia came in with angina and dyspnea, and on clinical examination her pulse was weak, and on auscultation there was a systolic murmur that was louder after S1 and got quieter and quieter by the end of S2. This systolic murmur that was heard sounds like a crescendo-decrescendo murmur that's seen in aortic stenosis. Now, based on the symptoms, angina and dyspnea, her age, and the clinical examination, weak pulses, and systolic crescendo-decrescendo murmur, we can assume that Antonia suffers from aortic stenosis that's caused by calcification and fibrosis around the aortic valve. Echocardiography showed stenosis of the aortic valve. Now, Mark has a history of rheumatic fever and is complaining of dysphagia. On clinical examination, his voice was hoarse, and on auscultation, a snap is heard after S2 with a diastolic rumble after the snap. Based on his history of rheumatic fever, his symptoms of dysphagia and hoarseness, and auscultation, we can assume that Mark suffers from mitral stenosis and his left atrium might be really dilated, compressing the esophagus and the left recurrent laryngeal nerve. Echocardiography confirmed mitral stenosis and a dilated left atrium, and ASO titers were elevated.
Clint is a 19-year-old male that's brought to the emergency department for acute chest pain. Upon examination, you notice that his heart rate is really fast, about 170 beats per minute. He has a history of depression and is currently being treated with TCAs. He is otherwise healthy. A few minutes after arriving, Clint loses consciousness. His ECG shows this. Alright, so based on his presentation and ECG, Clint has some form of arrhythmia. The best way to approach arrhythmias is to 1. Know what a normal ECG looks like, and 2. Have a good classification system to narrow down the diagnosis. To help identify an irregular rhythm, you can look at the morphology of the waveform and make sure that there is a P wave before every QRS complex, and a QRS complex after every P wave. Now let's look at the heart rate. The resting heart rate beats at a rate between 60 to 100 times per minute, and each of those beats starts off with depolarization of the sinoatrial node, and so we call it a normal sinus rhythm. It's also important to know that there is typically a delay in the conduction at the AV node and the bundle of His, which gives some time for ventricular filling before the ventricle contracts. On the ECG, this is represented by the PR interval, which should be less than 5 small boxes or 200 milliseconds. Now, any disturbance in the rate, rhythm, site of origin, or conduction of the cardiac electrical activity is called an arrhythmia. Arrhythmias could be completely asymptomatic and be picked up incidentally on an ECG. Arrhythmias can also present with palpitations, which is a sensation of your heart beating too hard or fast, fluttering, or skipping a beat. Additionally, they may alter cardiac output, causing individuals to present with signs of hypotension and decreased brain perfusion, like dizziness, altered mental status, or syncope. If an arrhythmia is really fast, the heart muscles now demand more oxygen, and if oxygen supply is not met, then the myocardium suffers from ischemia, which presents as angina. In people with underlying heart disease, the sudden onset of an arrhythmia can precipitate acute heart failure. Finally, some arrhythmias may also cause sudden cardiac death. Now, arrhythmias can be classified into those originating from above the ventricles, supraventricular arrhythmias, and those originating in the ventricles, so ventricular arrhythmias. In general, what's important to remember for your exams is that supraventricular arrhythmias have a narrow QRS complex because there's a rapid excitation of the ventricles, which means the arrhythmia is originating above or within the bundle of His. On the other hand, ventricular arrhythmias have a wide QRS complex because there's a slower spread of ventricular depolarization. Okay, now the two types of ventricular arrhythmias are ventricular tachycardia and ventricular fibrillation. Ventricular tachycardia, or VT for short, originates from an ectopic focus located in the ventricle. The two main subtypes are monomorphic and polymorphic ventricular tachycardia. On ECG, both appear as wide QRS complexes, at a rate ranging between 120 and 200 beats per minute. Monomorphic means that all the QRS complexes look the same, and it's classically a complication of myocardial scarring due to acute myocardial infarction. On the other hand, polymorphic means the QRS complexes have different shapes in each beat, as they come from different areas of the ventricle. This may occur due to acute myocardial ischemia, causing the pacemaker cells to be stressed, and it's not associated with myocardial scarring. Another cause of polymorphic VT that is frequently tested in the exams is Brugada syndrome. This is a rare autosomal dominant condition characterized by genetic mutations hitting cardiac sodium channels. Now, the test question will typically describe a male of Asian descent, whose ECG pattern in V1 to V3 shows pseudo-right bundle branch block, with the widened QRS presenting an RSR configuration, as well as ST elevations. Now, some individuals affected may present this ECG pattern and yet be asymptomatic, while others may present symptoms like syncope. Regardless, they're all at risk of developing polymorphic VT and sudden cardiac death, so treatment is primarily focused around prevention with implantable cardioverter defibrillators. A specific and very dangerous type of polymorphic ventricular tachycardia is known as torsade de pointe, which is French for twisting of the points. This is because on ECG, the varied QRS complexes give off the appearance that they're twisting around the isoelectric baseline. For your exams, remember that torsade de pointe is associated with anything that prolongs the QT interval. This includes diseases with genetic mutations hitting ion channels, most often potassium ones. Examples of these diseases include Jervell and Lang-Nielsen syndrome, which also causes deafness, and Romano-Ward syndrome, which is not associated with deafness. A prolonged QT interval can also be due to electrolyte abnormalities, and especially hypokalemia, hypocalcemia, or hypomagnesemia. On your exams, look for clinical scenarios that may cause these electrolyte abnormalities, such as someone with diarrhea who loses tons of potassium in their stool and subsequently develops an arrhythmia. In addition, many medications can prolong the QT, and this is frequently tested. To help you remember them, think A, B, C, D, E, where A is antiarrhythmic, type 1A, 1C, and type 3. B is antibiotics, like macrolides. C is for antipsychotics, like haloperidol, olanzapine, and ziprasidone. D is for antidepressants, like tricyclic antidepressants. And finally E for antiemetic, like ondansetron. Now, regardless of the cause, remember that torsade de pointe must be quickly treated with intravenous magnesium sulfate, as it can rapidly progress to ventricular fibrillation. In many cases, ventricular tachycardia can progress to ventricular fibrillation or VFib. High-yield triggers include acute myocardial infarction, heart failure, shock, hypoxemia, or hypercapnia. In ventricular fibrillation, the heart's muscle fibers start quivering because they're not contracting at the same time. On ECG, the whole PQRST pattern breaks down completely, and there are no actual QRS complexes, just random undulating waves. And it's important to be able to recognize this pattern since the situation is extremely dangerous. Essentially, the heart's not able to squeeze anymore, so there's no cardiac output. As a result, your body, especially your brain, isn't getting fresh oxygen. That's why ventricular fibrillation is one of the most common causes of sudden cardiac death, so it must be immediately treated with CPR and defibrillation. Alright, as a quick recap, an arrhythmia is any disturbance in the rate, rhythm, site of origin, or conduction of the cardiac electrical impulse. Ventricular arrhythmias are those that originate within the ventricles and have a wide QRS complex on ECG. These two types of ventricular arrhythmias are ventricular tachycardia and ventricular fibrillation. Ventricular tachycardia can be monomorphic, meaning that all the QRS complexes look the same, or polymorphic, meaning the QRS complexes are different in each beat. A specific and very dangerous type of polymorphic ventricular tachycardia is torsade de pointe, which presents a twisting pattern of QRS complexes. This can rapidly progress to ventricular fibrillation, in which the whole PQRST breaks down completely and is the most common cause of sudden cardiac death. Okay, back to our case. Clint's presentation describes palpitations and chest pain followed by syncope, suggesting something is going on with his heart. On ECG, you see a twisting pattern of QRS complexes, typical of the torsade de pointe. It was probably triggered by the TCAs he takes to treat his depression. You immediately give intravenous magnesium sulfate, successfully saving Clint's life. Moving forward, Clint should stop TCAs and switch to another antidepressant.